Welcome to the slides on glomerulonephritis, nephrotic syndrome, and polycystic kidney disease. Glomerulonephritis is a group of diseases that injure part of the kidney that filters the blood, or the glomeruli. Other terms you might hear are nephritis, nephrotic syndrome, and glomerulonephritis usually can cause nephrotic syndrome if we don't treat it in time. Basically, with any of these diseases, when the kidney is injured, it cannot get rid of our waste and extra fluid in the body, and that's how we're seeing the different clinical manifestations and complications of these three diseases. So first off, we're going to talk about glomerulonephritis. This is inflammation of the glomeruli. It's primarily affects the primary site of inflammation is usually in the glomerulus, but how we can have tubular, interstitial, and vascular changes within the kidney as well. Glomerulonephritis does affect both kidneys equally, and it's the third leading cause of end-stage renal disease. On page 1042 in your book, on table 45.8, there are different causes and risk factors for glomerulonephritis, but something to remember to help think of all of those causes is that it's an immunologic process involving the urinary tract that predominantly affects that renal glomerulus. One of the autoimmune diseases that's labeled in there is Goodpasture syndrome, and that's an autoimmune disease in which the body makes antibodies against the glomerulus and the alveolar basement membrane, which is why we see bleeding in the lungs. The most common type of acute glomerulonephritis is post-streptococcal glomerulonephritis. And this occurs because the complement system is activated as the antigen-antibody complexes are deposited in that glomerulus when they're getting filtered. The good thing is 95% of patients recover completely with conservative treatment. The glomerulonephritis, or the clinical manifestations, develop about 1 to 2 weeks following a streptococcal respiratory infection, and that is because of the nephrotoxic metabolites that are released by the group A beta hemolytic strep that again attack the glomerulonephritis, or those antigen antibody complexes destroy those little glomeruli. Clinical manifestations of glomerulonephritis include a generalized edema and hypertension. And if this is because we have decreased filtration rate. So if we're not filtering out that fluid, it stays, in the body, and then we can see the edema that ensues from that increase in the hydrostatic pressure. And then that will also cause our hypertension because of the body holding on to fluids. If we're not filtering, we usually have a decreased urine output, so that's that oliguria. Okay. Hematuria can occur from the inflammation and the destruction of that glomeruli. And then we usually see kind of a smoky or rusty colored urine. That smoky urine we usually see in Goodpasture syndrome. That has to more do with bleeding in the upper urinary tract syndrome. We also see protein in the urine, because with the glomerulus, they're not filtering like they should, but they let that, which means they don't filter out our wastes, they don't filter through the fluid, but they are so broken and damaged that they do let the protein through in the kidneys, and then we lose it in our urine. So when we're doing our UA, we can see blood in the urine, we can see protein in the urine, and we can also see a decreased urinary output. Treatment for glomerulonephritis is mainly symptomatic, and so that would be if we see hypertension, we would give antihypertensives or diuretics. The other big symptom is edema. So then again, diuretics are going to help get rid of that excess fluid volume and help with the edema. So edema and high blood pressure are definitely those symptomatic relief that we're looking at there. We want to rest, so rest and support the body, and while we're doing that symptomatic relief, sodium and fluid restrictions will help with that increased fluid retention by the body. If the proteinuria is extreme, or we are seeing an elevation in blood urea nitrogen, so that is the nitrogenous wastes of metabolism in our body. If we see those, we might decide to do a protein restriction in their diet so that it reduces the wasting there. If there is an active strep infection, which again, that streptococcal infection is the #1 reason for an acute glomerulonephritis. So if that is still active, we would treat it with antibiotics, but we are treating the strep infection, which is causing the kidney disease. We're not treating it. We're not treating glomerulonephritis with antibiotics. We're treating the underlying reason. And then we would want to educate patients on prompt treatment for strep infections for themselves, and kind of educating them on getting prompt treatment for, family members, and what those signs and symptoms are, like sore throat, fever, dysphagia. This leads us to nephrotic syndrome. This is it can be a sequelae of our glomerulonephritis, and this causes proteinuria that leads to low plasma albumin and then tissue edema. So our glomerulus, again, it is damaged, and it leads to excessive permeability of proteins. So then our proteins, we're going to see it in the urine, and we're not going to see it in the vasculature space where it should be. For nephrotic syndrome, a third of the patients are going to have an autoimmune disease such as systemic lupus, erythemaitis, or they have diabetes. There is a list of other causes, but the main cause of nephrotic syndrome is going to be uncontrolled diabetes and that SLE or lupus. So clinical manifestations of nephrotic syndrome, it's going to be usually more advanced than the glomerulonephritis. So we see peripheral edema for the same reasons as we saw it with glomerulonephritis, okay? And we see it more exaggerated because of the excessive loss of the proteins in the urine, and we don't have it in the vasculature. We also lose proteins such as our anticoagulant proteins, and so we can see a hypercoagulable state, and this puts the patient at high risk for thromboembolism, which is a very serious complication of nephrotic syndrome. 40% of nephrotic patients who develop a thrombosis usually develop PE, and these thromboses usually develop in the renal vein. When our body is losing proteins, the liver, with its biofeedback mechanism, it's going to start breaking down some fats, and that will cause hyperlipidemia in our body. So with that hyperlipidemia, it can cause this foamy urine, and so that is going to be highly elevated, triglyceride levels is when we're going to see our foamy urine. So this would be a very late consequence of nephrotic syndrome. And then, of course, with the protein lost, like albumin in the urine and not in the vasculature, we see signs and symptoms of hypoalbuminemia, which we've talked about in the previous module. And then we see ascites development and anasarca, which is severe peripheral edema and swelling. So how do we treat nephrotic syndrome? Well, we again treat the symptoms, which we would focus on edema and hypertension. With nephrotic syndrome, we can also treat it with corticosteroids and the cyclophosphamide, which is like an anti-rejection medication. Patients with nephrotic syndrome usually don't have a good appetite, plus they're losing a lot of proteins in their urine, so they don't have good protein where it should be in their body and usable. So we would want to increase their intake, of foods to keep the energy demands up, and also small frequent meals will help because of their lack of appetite. Because glomerulonephritis and then nephrotic syndrome are primarily of a autoimmune disorder. They're at high risk for having complications due to infection. So we want to make sure that they take good, hand hygiene, that they take good measures to avoid exposure to having any sort of infection. And then lastly, with their edematous appearance and that really tight swelling, ascites, and possibly with a paraorbital edema, we want to help them cope with that altered body image, so having some psychosocial nursing management as well. Other management techniques for nephrotic syndrome, which we alluded to earlier, are going to be antihypertensives. So we can use ACE inhibitors. Sometimes the NSAIDs can cause that damage to the glomerulonephritis through the autoimmune disease. So that's why we're saying cautiously use those medications, as well as if our GFR is already impeded, we don't want to use ACE inhibitors because that can cause a hyperkalemia. Low sodium for the fluid retention. Moderate protein, again looking at our urine, and if it's excessive, we may need to monitor and to change the intake of the protein there. Diuretics to help with the fluid overload, the hypertension, and to help monitor these patients, we'll have them take daily weights so that we know if their diuretic therapy is working or if our other treatment options are helping. So are we losing edema? Are we getting smaller? Are we losing weight? So taking a daily weight every day, we could potentially measure our abdominal girth and doing intake and output records meticulously. Going back to anticoagulant therapy, that would only be if the thrombosis did occur. So again, it starts in the renal vein and it can cause PE in about 40% of patients. And if the liver has kicked in and caused that hyperlipidemia, we can add medications to manage that as well. Our last disease we'll talk about with the kidneys is polycystic kidney disease. And this is the most common genetic disease in the world, which accounts for almost 20% of chronic kidney disease in the United States. There's a childhood form, which is rare, autosomal recessive, and it is rapidly progressive. And then there's the adult form, which is autosomal dominant. So if a patient is diagnosed with PKD, there's a 50% chance that there's a 50% chance in every child that they could also develop polycystic kidney disease. The adult form is latent, and we usually show symptoms in the 3rd or 4th decade. Thus, a lot of people already have children by the time that they know they have polycystic kidney disease. So when we get into the slide about treatment options and psychosocial considerations, we might want to do genetic counseling to educate the patient about the incidence of PKD, and we could refer them to a geneticist to see if they want to find out if their children will have it. PKD involves both kidneys, and it affects both men and women equally since it's autosomal dominant. Here's just a picture of the cysts growing. So when the cysts grow on the kidney, they are very thin, fluid-filled sacs, and they cause damage to the kidney because they compress the nephrons and the functioning parts of the kidney so that they don't function like they should. Most times, individuals have no symptoms until renal failure occurs, or they might not have any symptoms at all, and we'll find PKD on different imaging studies that we did for a different problem that they presented with. However, when the symptoms do occur, it's usually when the cysts are enlarged. And the first sign we see is headaches, UTI, or kidney stones. We also can see hypertension, because again, we don't have the functioning of the nephron and the filtration like we should. And then we can see hematuria if those pockets and cysts, break, and then we see blood in the urine. Chronic pain is a very common symptom. It can be severe, it can be constant, it can be acute, so coming in with abdominal pain. And then if the cysts are large enough, we may feel kidneys on palpation of the abdomen. PKD can affect lots of other organs in our body. It can cause cysts in the liver, it can cause abnormalities on our heart valves, and it can increase the risk for aneurysms in other parts of the body. And so the most serious complication of PKD would be cerebral aneurysm, causing subarachnoid hemorrhage. We diagnose PKD based on clinical manifestations, family history of the disease because of the genetic etiology. Ultrasound is the best screening measure to see those cysts and if they're fluid filled or not, but a CT will give more precise imaging of the kidneys. There's no specific treatment for polycystic kidney disease, but if there's chronic or serious bleeding, infection, or pain noted because of the size of the cyst and the hematuria, or the problems with the kidney, we can do nephrectomy, so completely removing the kidney, or if it gets to the end stage renal disease, and the kidney is no longer functioning, we would do dialysis to support the body functions, or the patient could be on a kidney transplant list, and then that would obviously cure PKD because it would be a brand new kidney. Lastly, nursing care of a patient with PKD would be similar to end-stage renal disease, and that includes diet modification, sodium and fluid restriction, treating hypertension, and psychosocial support because of the chronic long-term nature of this disease. And then I alluded to it earlier, but genetic testing and counseling should be offered to patients so that they can make decisions about possible child rearing or make plans for the future. Thank you.